Would like to invite the first speaker up. Abdisalan Noor is the team lead for surveillance at WHO's Global Malaria Program. He is also the lead of the World Malaria Report and will be speaking to us about the global burden of malaria, its trends, the methods and challenges and data that go into that. Thank
you. Thank you, Philip, and thanks, Gina, for inviting me to the Alan Magil Symposium. Today I'll talk to you about the methods the WHO uses to estimate the numbers of malaria cases and deaths in the World Malaria Report, which is released every year. This is a signature document for the Global Malaria Program and the larger World Health Organization, and not because I'm the one who's leading it. I've only been responsible for last year's World Malaria Report and this year's, but because it actually is the singular platform to track national, regional, and global progress against the fight against malaria. Today, in my presentation, I would first of all like to perhaps impress upon you how critical this document is to shaping the global policy, the global malaria policy, how also help you recognize that currently it contains the best official estimates at national, regional, and global levels, and take you through the methods that we use to estimate the burden of disease, but also recognizing that there are important limitations and present to you a suggested way forward in terms of improving on the methods and subsequently the numbers that come out of these methods. There are, you would have seen the data presented in last year's World Malaria Report. We're just finalizing this year's World Malaria Report, in which we will be reporting trends up to 2017. Last year's report showed that progress had stalled, both in the morbidity of malaria and also in malaria mortality. The subsequent results shaped the discussion around the path for the future in terms of global malaria policy and what we need to do to get back on track for the global technical strategy. This has had important implications across the partnership and the regions, and also some of the debate that's ongoing in the highest burning countries that are contributing to the globally us being off track for the GTS targets. So that is all about I'm going to say about the importance of this document. In terms of the methods, we use 3 methods to estimate the burden of morbidity and 3 methods to estimate the burden of mortality. Before I go into the methods, I'd just like to recap. When we say the burden of malaria, many people have different ideas of it, and it's got multiple metrics. What I show here on this chart is essentially the different things one looks at from infection all the way to deaths. What the Global Malaria Program report focuses on is direct malaria deaths and direct malaria cases. And just to say that across the estimation process, while we know that the magnitude of the burden is higher at level of infection and reduces all the way to deaths, the uncertainty in the estimation of these metrics increases from the measurement of death, which is extremely controversial, all the way to the simple measurement of infection in an individual's bloodstream. Now, the methods to estimate malaria morbidity. There are 3 main ones. The first one, which applies to about 23 countries, is just the use of the actual data. These are countries which have extremely low malaria burden and overall contribute to just about 0.5% of the global malaria burden. Then there's a subset of countries, about 49 of them, most of them outside of Africa, but a few countries in Southern Africa, which also have low malaria burden, reasonably good surveillance systems, but have gaps in the surveillance system with respect to the public sector, which reports mainly to the WHO, not capturing all the events, as well as an incomplete diagnosis rate, and in some instances, an incomplete reporting rate. But the bulk of the estimates come from one single model, which is the conversion of parasite prevalence to incidence. And I'll focus in the next couple of slides on, first, the adjustment of the routine data. There are three main things that concern us in the adjustment of the routine data. One is the testing rate. What's the proportion of individuals who are tested? The second is the reporting rate. What proportion of reports are received by the country and the NMCP from the health facilities? And perhaps the most important, which has the biggest impact on the estimates, is the treatment seeking. So what proportion of cases are likely to be captured in the public sector? This is just a diagram to show you the different corrections we make to the routine data. But what I would like to dwell on is really the impact of treatment seeking. The information we use to adjust the routine data for treatment seeking comes primarily from household surveys, and it's focused primarily on the treatment seeking among children under the age of 5 years who had fever in the last 2 weeks. And the surveys normally capture the different pathways to treatment, and by and large divided into those who have sought treatment from the public sector, the private sector, however you define it, from the informal retail sector, and those who have not taken any action at the time of survey. And so once we get the routine data, which comes primarily from the public sector, then we assume an equal distribution of risk among the other groups, those who sought treatment in the private sector, in other sectors, and those who do not take action, and apply that correction. But there are a number of problems associated with this adjustment. One is we do not know how useful self-reported fever is as a proxy of malaria fever treatment. We do not know whether fever treatment among children under the age of 5 years is a good proxy for what happens in older children and adults. We do not know whether the probability of having an infection is similar across those individuals who seek treatment in the public sector compared to those who don't seek treatment or who seek treatment in other sectors. And to understand the downstream impact on mortality, we need to know whether these individuals have been treated with effective treatment, and that is a major gap. Now, with all this uncertainty, we still apply this correction. In terms of the parasite rate to incidence model, the entry point is estimating parasite prevalence through a model-based geostatistical model. The person who leads that work is Pitt, who would be the last speaker of this session, who is leading the Malaria Atlas project. And once we have estimated parasite prevalence, we apply epidemiological models to convert the parasite prevalence to incidence using a model that quantifies the relationship across different age groups and transmission patterns between transmission and case incidence. And the outcome is the expected number of fevers attributable to malaria at different ecologies across different age groups. Now, there are a number of important limitations in the process. The first one is parasite prevalence come from household surveys. There's an important temporal latency every 3, 4 years or 5 years. Some countries once every 10 years. The times when you don't have data, and in areas where you don't have data, the biggest drivers of the prediction is the determinants such as climate, intervention, and others which have a significant influence. And importantly, it's creating a situation where countries are gradually not believing in the estimates, largely because what the model is estimating in some countries is discordant with what's coming from the routine system. In the conversion of parasite prevalence to incidence, there are also other important problems, such as the active surveillance data we're using is relatively old. There has been a significant shift in transmission and also a significant shift in the age-related immunity. And we do not have a good handle on the effect of access to effective treatment on the burden of disease and subsequent mortality. In terms of, so if you look at the way forward for those countries in Africa where we largely rely on the parasite prevalence to incidence model, the question is it time to adjust to the use of routine data? And I'm one of those who believe that in many of these settings, it is time to adjust to and fall back on the routine data. It improves largely because there has been significant improvement in diagnostics and significant improvement in reporting. Just to illustrate this, since 2005, we've had 1 billion tests among patients of all ages in sub-Saharan Africa. This data in most countries is available monthly. It's got a lot of biases, but nonetheless available. In the same time, about 2 million tests in children under the age of 5 years in household surveys, done every 3 to 5 years. So there's a significant difference in terms of the volume of data that's coming up to you and the temporal resolution, and to an extent, the spatial resolution of this data. Now, just to illustrate the differences between if we were to start using the routine data and if we relied on the parasite to incidence data, this is an example of Nigeria, which the parasite rate to incidence model estimates about 48 million cases in 2017. The routine data reports about 12 million cases who are confirmed positive. When you adjust for reporting rate and testing rates, the adjustment gives you about 26 million. One is just cases in the public sector. The other one is population-wide estimate of the incidence of disease. There is a fundamental difference in terms of the outputs, in the sense that the parasite rate to incidence model estimates malaria attributable fevers. The public sector reports essentially individuals who have fever suspected to have malaria and who have been tested and returned a positive test. That aside, we know from the household surveys that the use of the public sector in Nigeria is about 25%, which means if we assumed homogeneity of risk of infection in people who use other sectors who don't seek treatment, we might be essentially missing out on a large number of cases. The adjusted routine data population-wide might suggest up to 80 million cases of malaria in Nigeria. Now, this is not to say that the routine data is better than the parasite rate to incidence model or vice versa, but to show you that two methods that are approved by the WHO and used by the WHO could give you significantly divergent estimates depending on the context. The same applies to some of the high-burden countries. Now, when it comes to mortality, again, we use three methods. One is basically the actual data reported from the countries. Another one is adjustment of the routine data. And the largest bulk of the estimates come from an all-cause adjustment for the cause of death fraction, largely based on bubble autopsy estimates of the malaria attributable deaths. Now, the problem with the routine data, when it comes to adjusting for mortality, is we have the problems that affect the quantification of estimates of incidence, because we apply case fatality rate to that in the countries where we use the routine data. We use a static case fatality rate, which comes from really old data sets, and some of them not representatives of the context where we are making these adjustments. In terms of the data coming from the adjustment of the bubble autopsy cause of death fractions, which contributes nearly 90% of the case counts for deaths we report in the World Malaria Report, these are largely based on a bubble autopsy system that assumes there's a cause of death assigned to that particular death, which then uses a number of covariates to quantify through an envelope the proportion of cases that might be attributable to malaria, which globally now stands at 5%. To adjust that with any of the new data requires a large process of bargaining. It becomes a marketplace of deaths really for the diseases. And changing the attribution from 5% for malaria globally to anything like 6% means you have to take percentage deaths from other diseases, which is a really complex process. Now, it has a number of limitations, both related to the covariates that are used and the corrections for over 5 and the inherent problems of using bubble autopsies. And this is just an example of some of the data we use for correction for over 5, which is really bad and extremely old. And this comes to when I talk about some of the ways forward in terms of how to improve the estimates. But before I go to potential processes to improve the estimates, this is just an example of the relationship of parasite prevalence, which is the main covariate in the cause of death fraction, and the cause of death fraction in terms of trends. If the trends were equivalent, you would expect a ratio of 1. But you can see by country a significant divergence from the dashed line, largely because year on year there's a significant smoothing in the process of quantifying cause of death, which affect the relationship of cause of death fraction with PFPR and subsequently the malaria attributable deaths that come out of this model. To address some of these problems, the WHO convened an evidence review group in March this year. The detailed report can be found on that URL. But to end my presentation, there were 6 key recommendations, which is improving the existing parasite prevalence models, improving the way they're used to convert parasite prevalence to incidence, increasingly using the routine data and getting a good handle on the biases in the routine data, beginning to track other metrics of burden of malaria to contextualize both cases and deaths, but also primarily because they're important, such as anemia and severe disease. And for anemia, we're going to report it for the first time in many years in this year's World Malaria Report. Improving the assumptions in the way we estimate mortality, but also in terms of research, beginning to think about comparative studies that compare the clinical incidence and prevalence across different settings and try to quantify the effect of the different pathways for treatment seeking. Thank you very much.